Welcome to episode 208, Caring for Palestinian Clients Through Trauma, Limitations of Western Norms and More Fitting Approaches, featuring Dr. Samah Jabr. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical, learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am sincerely honored today to be joined by Dr. Samah Jabr. She is the head of the mental health unit for the Palestinian Ministry of Health, and she's joined us today as both a psychiatrist and a psychotherapist for a conversation about what mental health professionals need to understand about what's happening in the conflicts in Palestine and how Palestinian people are affected, and also how we as mental health professionals can show up more effectively when working with clients who've been affected by the crisis unfolding in Gaza. I am sincerely grateful. Thank you so much for joining us today, Doctor.
Thank you very much for having me with you. It's a great pleasure for me as well.
So for folks who are listening, can you please tell us a little bit about yourself and your background, and then we'll dive right into our conversation today.
I'm a consultant psychiatrist. I finished my studies in France, and I have been working in Palestine as the head of mental health services. I've been working as a psychiatrist for 18 years, but as the head of mental health services in Palestine for about 8 years now. My work includes clinical activities, working with patients, providing supervision for my colleagues, and drafting mental health policies for Palestine.
Fantastic. Thank you for taking time out of your busy life right now to have this conversation. In talking with you prior to recording, you had shared just how it feels like the Western approach is missing the mark when it comes to understanding the unbelievable trauma that's occurring and what's affecting Palestinian people right now. Why don't we start there, just in your perspective as someone who's able to kind of see this from the top of where we're kind of missing the mark in supporting people who are affected by the current crisis?
Yeah. First, let me point out that the majority of mental health literature is written from a Western perspective, a vast majority, and little knowledge is generated from places where there is oppression and conflict zone. So sometimes the assumptions that are made by the hegemonic mental health institutions and hegemonic mental health literature do not apply to the situation in Palestine. And we learned that by experience. Many of we are few mental health professionals working in Palestine, but most of us are trained abroad. And when we come to practice, we are faced with an unusual situation. For example, when I trained in France, my chef de service, the person who was supervising my clinical activities, he received 5 patients per day. In Palestine, in a community mental health center, we receive 60 patients per day. That's the average number. Sometimes it can go higher. So this is just an example that made me question the applicability of Western mental health to the Palestinian reality. I will mention a few challenges that we experience here. You know, Palestine is being supported by many international mental health organizations. And for them, in order to enroll someone in therapy, they need to give a diagnostic to enroll that person in a diagnostic category. So they give a label, and the most commonly used label is PTSD. So I started questioning the applicability of post-traumatic stress disorder in the Palestinian situation, because in my experience, there is no P in the Palestinian experience. We're never in the post. A person who suffered from torture, for example, they go out of prison, but they are exposed to many stressful situations and the high possibility that they will be re-detained. So the threat is present all the time. So PTSD is a diagnosis that can best capture the experience of an invader, of a soldier who moves from the safety of his home to the battle land. They experience difficult things, they go back to the safety of their home. The threat for them is when they go back to the safety of their home, the threat is imaginary. While for the Palestinian, the threat is very real. And usually people don't have the experience of, like, the symptoms that people present with are not the usual re-experiencing hypervigilance, avoidance. It is more than that. Avoidance in the case of a Palestinian can be an appropriate reaction, an appropriate behavior to avoid situations that bring harm. While avoidance for a person with PTSD who is in safe conditions might be a pathological symptom. So, those are some of the observations that made me and other colleagues like myself question the applicability of Western terminology and Western approach in the Palestinian experience. I want to say that the Palestinian experience can better be understood through the lens and the framework of historical trauma because of the characteristics of the experience that people live. We are talking about colonial, cumulative, collective, and cross-generational trauma. Historical trauma is a mass trauma that is inflicted against a target population by a dominant subjugating power. And it reverberates through the population, generating many traumatic reactions that are not limited to the symptoms of PTSD. And it has the capacity to, and the magnitude to change the natural projected historical course of that nation, creating, for example, many disparities like economic, social, physical, health, and psychological disparities across several generations. So those characteristics apply to the Palestinian situation and make us see that there are many individuals who are damaged by their direct exposure to trauma, but others are damaged by a traumatic experience that happened to their grandfathers, to their fathers, to their classmates, that happened in their neighborhood, the attack on the identity, the attack on the representation of your people, and you as an individual, you are affected with the negative representations that are created by you, and people suffer for all of these things. One more thing is that DSM has a definition of trauma that doesn't take into consideration many of the bad experiences that qualify as traumatic to Palestinians. So the DSM definition of trauma includes harm, physical harm, or threat, or sexual harm happening to a person. But for example, burning your olive groves, confiscating your land, experiences of humiliation, they don't they are not considered as traumatic by the textbook. So all of that makes us question the applicability. And there is more to say about, so this is one example regarding the diagnosis of PTSD, but I think the homeostatic approach of Western psychiatry, of Western mental health, and the individualistic approach, the ahistorical approach, the overemphasis of neutrality, and the avoidance of taking any political posture regarding what's happening in your environment. This is convenient for a Western mental health professional, but it is not possible for a person coming from our world. Also, the scientific approach and the overemphasis of the scientific approach. The scientific approach is usually conducted, science and evidence-based research is conducted in the West for Western people. So to assume that EMDR is suitable for Palestinians is questionable, given the collective nature of our trauma. Can we provide individual responses when trauma is experienced by masses of people? Can we Palestinians, with very small number of professionals, put every Palestinian on therapy chair and provide trauma focused CBT or EMDR? Or do we need a different approach like healing circles and group interventions?
Thank you. You just covered so much information, Doctor, and I want to unpack some of it. I know this is a fantastical question. If you were to revamp the DSM and modify or create a new diagnostic category for people that are living in this degree of trauma with such an extraordinary threat, as you said, that the post doesn't really exist for post-traumatic stress disorder, what would that look like for you?
I think I would include the concept of historical trauma and the soul wounds that people in colonized countries suffer from. And yet there are many things that we observe and for which we have no language and no terminology that is suitable. I have to say that, okay, Palestine has been going through historical trauma over 100 years now, and we have been questioning the applicability of Western approaches in mental health. But I have to say that what we have been doing here is creating a system that relies on many people in the helping profession, like nurses, general practitioners, school counselors, teachers, a trauma informed care provided in the educational system. 1/3 of the Palestinian population are in schools, and in primary healthcare, which is a vast system. This was our response to the very small number of highly specialized mental health professionals that are available in the country. Yet, all of that, all of our efforts to respond to the ongoing challenges in mental health have not been sufficient to respond to the crisis in Gaza. Because the situation in Gaza is a situation where there is no place, let alone safe place. People are trained, like many lay people, non-mental health professional people, are trained to provide psychological first aid in times of crisis. But with no place, with no safety, no safe place, the absence of basic needs of shelter, food, drinkable water, medicine, mental health is not prioritized, and it's difficult to provide intervention. During COVID, in many countries, including Palestine, we upgraded the capacity of our health professionals to provide distant therapy, distant support, mental health support to people. With no internet and electricity, we could not respond to the crisis in Gaza. So, what do we do in such a situation? We observe We observe how people try to help themselves. And I have been observing. We saw people making circles for children, allowing children to chant national songs, for example. Women gathering and trying to collect grasses and provide anything to help people survive when food items are not present. So I think we noticed also that people bring up national values and faith values and use them in responding to the crisis. And I have to say that we need to accept and respect the organic ways in which people try to help themselves and imitate that. Because if we support people who try to support themselves, that is meaningful to them. I want to bring an example also from the West Bank, where a woman was treated by one of my colleagues for depression. This woman lost her child due to political violence. He was killed. And she said that many sessions of therapy could not help her. What really helped her move out from home and find her life again is the support of other women who had the same experience. They came to her home all the way from the north to Jericho to the south, and they visited her. They created a WhatsApp group. They started sending her messages. They invited her to go there. And this kind of help from people who went through the same experience was very meaningful to her. Now, this is not evidence-based practice, but if people tell us this was helpful, we need to listen to that. And we need to encourage initiatives like that and try to back them up with what we know is useful from evidence-based science, so that people can feel that this intervention is suitable for me and it meets my needs.
You bring up a very important point in acknowledging the safety factor, and that the lack of safety naturally creates an environment where it's not ideal to give mental health treatment. And also, how could you possibly be doing an evidence-based practice in an environment where you can't control variables, as you said, as we would want to do, to be able to say, okay, this study has revealed that this is most effective. And it sounds like what you're saying in your observation and in your colleagues' observation is the importance of all mental health professionals, particularly Western mental health professionals, following the structure that the people have already set for themselves. This is what works: to create a circle, to let us heal together, to have an environment that is something that could actually be replicated. As you said about EMDR, here we are taking a model that works here for someone who's going to a safe outpatient clinic with no threat to their safety, and also what has been designed and researched by Western people in a Western environment, and trying to apply it to a population where it's never even been tested.
Yeah. And I think we need to bear in mind also, in addition to that, that in places where there is oppression, there are limitations to our knowledge of truth. People will not bring all their truth because they feel threatened. And this is a very important epistemological difference between places of safety and prosperity and places of colonization, oppression, and marginalization. we need to take into consideration that people are not telling us everything. Even if they trust us as individuals, as therapists, but there is something in the environment that is not that cannot be trusted. They fear repercussions, reactions. They fear sometimes my patients who don't have any psychotic symptoms, they ask me to get my computer out of the room if they want to say certain things. And I know that others don't even want to talk about things that might risk their safety. So this is one limitation to research, and how can we generate knowledge and truth in oppressive situations. Another limitation, another big difference, I would say, is the homeostatic approach. In the Western assumption, the goal of treatment is to go back to the pre-morbid conditions. In Palestine, the pre-morbid situation is morbid by itself. The context is morbid. And people want to change the status quo. So the homeostatic approach is not suitable in many of the cases that we deal with. Even they look at some symptoms, like some symptoms which are considered to be pathological in from to a Western clinical eye, they are not necessarily pathological in Palestine. Take, for example, anhedonia, which is a common symptom in depression, and sometimes one of the negative symptoms of schizophrenia. We frequently encounter people who suffer from injustice in Palestine. And oppression, colonization, experiences of injustice can make people suffer from loss of joy. And that is an appropriate reaction. It's not a pathological reaction. I want to give you this clinical case that came to my clinic. A 13-year-old boy from Jerusalem. His mother told me that he had good performance previously, but now his grades are dropping, and his teachers say that he doesn't pay attention. And she wanted methylphenidate for him to improve his concentration and attention. So I chatted a little bit with that boy, and he explained to me that he deliberately doesn't pay attention in defiance to the imposition of the Israeli curricula in his school. So he goes to a Palestinian school. It was, we know that in certain schools, there was a change in the curricula that students study, and there was an imposition of the Israeli curricula. This boy didn't want to leave school. He could not leave school. So he stayed in school. But when in history classes, he places his head on the desk and he doesn't pay attention. And this is how he shows his defiance to this imposition. Now, if we don't listen to the full story, we can easily pathologize this person. But when we try to encourage a story that takes into consideration the environment, what's happening in the context, and the history, when did that symptom start? In reaction to what? I think those aspects that are related to the colonial experience, they can emerge and they can help us understand the situation in a different way. I will give one last clinical example in relation to your question. And this is a very recent example that I observe. I've been a clinician for 18 years, and for the first time, I see this kind of cases. Cases of severe weight loss, 4 of them were brought to my clinic over the past few months. And they don't have the usual body image concern. When I talk to them, some of them reveal different causes. They and their family members, I'm talking about young people, so the family was involved in some of the sessions, they said that the child stopped eating in reaction to the weaponization of starvation in Gaza. So it is a traumatic reaction. When people are being starved, when we see people in Gaza searching for their food and they get killed while searching for their food, when we see aeroplanes dropping food and it's falling on the heads of people and killing them. So that created reactions in the West Bank and Jerusalem. And we started seeing people with severe weight loss. One of the girls, she started fighting with her father whenever he brings fruit and meat, because she apprehends that there will be a similar political violence and military attack in the West Bank. So she started hoarding beans and hoarding cans, and she didn't want her father to bring food. So there is relationship between what we observe in the clinic and what's going on in reality. Now, if I know that if I present this in a clinical conference, in an international clinical conference, some people will be unhappy with this kind of presentation. They will consider it political and they will try to hush our voices because we're talking about clinical observations that are related to the political situation. And there is this inappropriate overemphasis on depoliticizing mental health practice, which masks many of the meaningful experiences that we have. And then we are expected to provide evidence and randomized control studies to share our knowledge. But that is not within our means when we are going through severe violent situation.
I appreciate that you brought up the idea of pathologization of what are healthy and adaptive responses to a horrifying experience. And your earlier point, too, about the ongoing trauma. At this point, for anybody who could find themselves in that situation, the application of a diagnostic to describe what is so deep within the realm of human suffering simply seems inappropriate and ill-advised. How could we expect someone to have immaculate, perfect mental health or even stable mental health in an environment that's completely unsafe when our nervous systems are always activated because the threat is ever present?
Mm-hmm. That's a serious question. In my experiences in Palestine, I observe two methods of pathologizing people. One is probably a well-intentioned way. So I will give two examples of pathologizing Palestinian people. One example comes from the World Bank. The World Bank in 2023 published a paper concluding that 70% of people in Gaza and 50% of people in the West Bank suffer from depression. They arrived to their conclusions when they used the WHO-5, the World Health Organization, the well-being questionnaire with its 5 questions. And many people crossed the cut-off point and they concluded that these people suffer from depression. So they used the individual measurement unit to study the morbidity, psychological morbidity in Palestine. And the WHO 5, in my opinion, does not distinguish between an individual pathology and other kinds of human pain and human suffering. Of course, there are many people who suffer in Palestine, but by pathologizing them and saying that 70% of people have depression, we are not talking about the political conditions. We are pathologizing. The more we pathologize, the more we depoliticize. We're not talking about what's happening in the context and the morbidity in the context, and we are talking about individuals. And we risk providing individual response and medication to these people who suffer instead of dealing with the context, with economy, with violence, political violence, and all the morbidity in the context. Now, there is a different example of pathologizing, which is less well-intentioned. For example, I want to talk about a person who died due to hunger strike, Khadr Adnan, a political prisoner. This guy managed to free himself from political detention 5 times. And last time he attempted to free himself with political detention, he was left without the necessary medical support and he died, unfortunately. And Israeli media reported that he committed suicide. So by saying that he committed suicide in a society that stigmatizes mental health problems and considers suicide sinful, there is a character assassination of that person, changing his status from a model, a person who's using his agency to free himself, to a person who is sick, pathological, and committed suicide. That suicide was also the attribution of the behavior of the youth in Gaza who participated in the March of Return. Media, international media, instead of criticizing why they are met with violence that is killing them, they said, why do these young people go to the borders? They are suicidal. This is a suicidal behavior. So, yeah, I think the overemphasis on measuring Palestinian suffering by using the individual measurement unit risks depoliticizing and hypo-visibilizing the political violence that the Palestinians are exposed to.
Thank you for breaking that down. When considering that context, were you to have someone who's foreign to that region go into that region to provide mental health care, what would be the guidance that you would give them?
No, very good question. Already we have many internationals who come to Palestine with good intentions. They want to help. And I think it's very important for them to know the culture and to know the political situation, to get educated about the culture and the political situation, and to try be sensitive to the situation here. Also, we need equal collaboration. Collaboration, because usually people who come with international NGOs, they come as experts to help us. but we are the experts on our situation. So it's very important that they come with the intention and the readiness to learn also, and not, they might be experts on certain topics or on certain interventions, but we are the experts in ourselves. It's very important that they come with this preparation to learn and to be sensitive to our language, to our cultural values, to our spiritual approaches, and to the political situation. I want to give an example of certain NGOs that almost punished some Palestinian local therapists for accepting the use of the word martyr to refer to some individuals who lost their life in political violence. This is the language that any ordinary Palestinian uses. This is the way of ordinary Palestinians to glorify those who are lost to political violence. So, in the absence of a real justice process and any kind of recompensation, people try to give them this glorified label of martyrs. So, I know a colleague, a therapist, who followed the language that was used by the relatives of that person. So when in her response to the mother, she said, your son, the martyr, had this and this situation. And she was notified, and she had to go through hearings to explain why she accepted this term used by the mother. So that's the lack of cultural sensitivity that can be problematic sometimes when exhibited by some of the workers of international NGOs.
Thank you for sharing that story. I think it was a very clear exhibit of what you're speaking about. When considering these quote unquote symptoms that are completely rational in the context, as you said, anhedonia, how could anybody in that context where their life is continually threatened, the people they care about are always at risk, and their way of being is continually threatened, how could anybody be experiencing joy in that context? With that in mind, knowing that in the Western world, we're quick to apply that label. We're quick to even self-describe. Within the Palestinian community, what language is used to describe the experience? Because it isn't pathological. It's rational, it's adaptive. When it's not depression, when it's not post-traumatic stress disorder, is it completely depathologized and just a state of being that's only natural in the context?
I want to say that people, when they bring their symptoms to the clinic, they often use idioms of distress that include somatization or a somatic expression that explains the pain. They talk a lot about their hearts, their stomach, their heart, not necessarily if the heart is aching, but they will say, like, they will use metaphors that include parts of their body. And this is not surprising given that in most of our traumatic experiences target the Palestinian physicality. So people respond in a physical way. And there is a lot of somatization. That's why it has been very useful for us to train general doctors to identify many people who suffer psychologically, because they exhibit symptoms in a corporal way, in a physical way. People often talk about the unspeakable. For example, they describe what's happening in Gaza now as unspeakable. they talk about loss of agency and inability to react as a very, this can be described as a very bad symptom by them. You know, one of the, I like this definition of trauma. It's the disaster of helplessness when people lose their agency and feel that they are in a freezing mode, not able to respond to what's going on. So the they can describe loss of agency. They use now to describe traumatic incidents. We have terminology that is accepted in Palestine. For example, the original traumatic event that dispossessed two-thirds of the Palestinians out of their land, it is referred to by the word Nakba, which means catastrophe. So people talk about the catastrophe here, and everyone understands what do they mean by catastrophe. The events that took place in 67, they describe them as the Naksa, the relapse, the big relapse. So those are descriptions. They talk about their soul being annihilated or wounded by the events. I have to say that unfortunately we didn't research how the different vocabulary that people use to describe their different traumatic experiences. Those are my immediate, this is what comes to my mind as you ask me this question about how people use, express the traumatic events. There are some collective traumatic events that everyone knows the name for them, like the catastrophe, the Nakba and the Naksa, the catastrophe and the relapse. What's taking place in Gaza now is referred to by Palestinians as genocide, as ibadah. Still, the International Court of Justice has to decide. They talk about plausible genocide. They have to decide about that. And in their reaction to this is described as collective grief, soul wounds, annihilation of the Palestinian identity. People don't talk about it as an individual depression. And sometimes people don't even bring it up, like, because it is well known and it's happening to everyone. So they come to the clinic and they don't talk about it in a special way because they consider that it's common. Everyone, all of us suffer from this, and it's needless to talk about it. There is a sense of normalization.
With that in mind, if you as a mental health professional are, and actually as I'm about to say this, I'd love to hear your language. I was going to say, if you as a mental health professional are there to help improve somebody's mental well-being, and please, I invite you to modify that language in the way that makes sense for the context for you and your background. How and when do you decide to reach for an antidepressant?
Well, that's a very important question. Yes, yes. If my understanding is that the person suffers from endogenous causes of depression, it's not their own normal reaction to the pathology, the distress outside his body. So, and it's sometimes because we know that the indigenous factors interact with the environment. Sometimes it is difficult to see that difference, but we try to solve and help the person solve the conditions outside himself, or deal with them, or accept them, or talk about them. If that is not sufficient, and if the person exhibits severe depressive symptoms, then we can provide individual treatment for his individual problems. And that might include medication. So we try, how do we approach this? We try to help the person to explore his attribution, all his attributions about his condition. And the more we provide safety and freedom, the more they can talk about things outside themselves. And if we are convinced that the problem is not related to what's happening outside, and it's more a private thing related to his biology, related to the family history of depression, and so on. And then if the reaction is severe and to conditions out of the self that he cannot change, then we provide individual solutions.
What do you see your role being as a mental health professional in Palestine?
Mainly to provide mental health support to individuals who come to the clinic and to draft national mental health policies, suicide prevention policy, to the different parts of the fragmented geography of Palestine, taking into consideration the different social and political determinants of health and how they affect the mental health and the well-being of Palestinian people. And I find it integral to my role as a mental health professional and a doctor to do advocacy, to talk about violence that is generating suffering and pain and psychopathology for Palestinians. You know, as a mental health professional in the West, if you encounter a child suffering from abuse, a woman suffering from gender based violence, your role is not only to treat them or medicate them, but also to inform about the violence and to do what is necessary to support these people in seeking help to end the violence. And this is my approach locally. I think that advocacy, solidarity, witnessing, documentation are very important roles for a person working with marginalized, oppressed groups. And I have to say that if, to collaborate with international mental health professionals who want to be supportive of Palestinians, we very much appreciate it when this is motivated by a sense of solidarity and opposition to the violence and the political conditions that bring all this suffering upon Palestinians.
Thank you. Thank you for that answer. For the mental health professional in the United States who may be supporting people who are living here in the US, you've mentioned some interventions that you're seeing used and effective there. As you mentioned, groups, spaces where people can have safety and shared experience. Were you to be here in the United States working with people who are experiencing this from afar, who are watching their family members be affected, who can't contact their family members, who are in so much fear, would you reach for those same interventions? What would you do here in the United States do you feel would be more effective or more helpful for people that come from Palestine and are now in the US?
Yeah, I think it's a collective experience. It can be re-traumatizing for many people who observe from distance. Re-traumatizing if they were exposed to traumatic experiences due to political violence previously, not only Palestinians, but people from Yemen, people from Syria, people from Iraq, and many other nations. I think what's happening in Palestine now is stirring the re-traumatization of some people and Palestinians in diaspora. Palestinians in diaspora are 2/3 of the Palestinian people. It is important that these people get supported And I think that they can best be supported in groups, healing groups. I like the concept of healing circles and the symbolic expression to help people affected by Palestinian trauma for two reasons. First, in healing circle, the person feels that they don't lose their agency. They are in a position to help and allow themselves to be helped. In a healing circle, it's not, the relationship is not like being in an individual therapy with a therapist. With the therapist, you are at the receiving end. You don't show your agency. In a healing circle, people help each other. So you will be helping another person who suffers, and you allow that person to help you. You don't lose your agency. And that's very important for Palestinians who consider themselves affected by this situation, but they want to exercise their capacity to narrate and to tell what happened to them. So a healing circle will allow this. The other thing is the symbolic expression. Because people keep telling me it's unspeakable, so we would like to encourage them to draw their feelings or to sculpture their feelings. And, when there is oppression and people cannot say everything they feel or think, the symbolic expression and artwork becomes very important. So I think these two elements are important in. I heard from some colleagues helping Palestinians in the US. They told me that she said that if I call Palestinian women for a psychological intervention, they wouldn't come. But when I called them for an embroidery workshop, they would come. And while doing embroidery, they will be talking and reflecting on the events in Palestine, and they will be supported.
That's a beautiful example. Thank you for sharing that. As we're talking about this, the situation is ever evolving. As you've said, this continuing trauma. You've mentioned the importance of advocacy and this kind of simultaneous balancing between supporting the person or people that are right in front of you and then also advocating for them. In the United States Western method, if we're looking at psychological ideals from, we'll say 40 years ago, 30, 40 years ago, a lot of challenging of thoughts. This idea of cognitive behavior therapy, the limitations for this model. If you were to choose from the existing Western models for application to Palestinian people, granted that this hasn't been researched, what do you feel like is most applicable? Is it the true humanistic approach?
I think some elements from narrative therapy are very relevant, and some elements from trauma focused CBT can help certain individuals who exhibit severe symptoms of hypervigilance, re-experiencing, and so on. A systemic approach, family therapy. The one of the strengths of the Palestinian community is the family structure, and I think some elements from family therapy might be relevant. Now, the problem with these approaches is that they provide solutions for individuals, and we know in the Palestinian example, yes, masses of individuals are suffering, and that's why group interventions seem to be more cost effective for us, more feasible, more doable, more realistic. We cannot put every Palestinian on therapy chair. Yet there is a big damage to relationships, to the collective self-concept, to identity, to representation, to the social fabric. And I think Western interventions don't have a solution for that. The solution for that is the expression of agency, finding positive role models in the society, engaging in healing processes, healing circles, creating a national narrative that will contribute to healing and the process of justice, like the International Court of Justice and the South African move.
Thank you for sharing that information, and I appreciate your points about the value of models like narrative or humanistic, or even, as you said, trauma-based CBT. With all of that in mind, and your point about solidarity, standing with somebody witnessing, it seems all the more important for mental health professionals serving people coming from that region to approach it with cultural humility, with watching and learning and listening. And you said earlier, experts are coming into this region, but they may be bringing this expert's perspective that's applicable where they are, but isn't applicable here. If you had to recommend particular resources to mental health professionals in this context, what would they be?
I think it's important for mental health professionals who want to help Palestinians to inform themselves about the writings in liberation psychology. Ignatius Martin Barrow, Paulo Freire, Franz Fanon, and to read some of the Palestinian researchers like Rita Jaqaman, Nadira Shalhoub Koverkian. I've been also contributing some writings to media and in scholarly journals about the situation in Palestine and mental health in Palestine, touching upon topics like neutrality and mental health and justice and human right approach to mental health. I think this kind of reading will equip them with the necessary sensitivity to approach the Palestinian mental health reality.
Thank you. I appreciate that additional information. And I had asked you previously about additional resources. You had mentioned you have a number of books. The limitation for me as an English speaker being that they're not in English. I would still like you to share them. In case we do have multilingual clinicians listening that want to look at these resources, but I don't want to limit access simply by the language factor.
Sure, I can share some of these. So we have Derrière les fronts, Beyond the Front Lines, Behind the Front Lines, a collection of articles. It's published in French, Italian, Spanish, and Portuguese. And the other book with the title Sumud, that's the Palestinian word about resilience, the resilience. It's more than resilience, but it's our Palestinian word to express the steadfastness and perseverance of the Palestinian people. It's published in Italian.
Thank you. I appreciate you sharing those resources and appreciate all of the work that you're doing on so many levels and bringing attention to this. These are conversations that may be overlooked, particularly when we only have what we see in the news. And it's so helpful to hear from someone like you who has such intimate experience of what is actually unfolding and what we can do as mental health professionals to support people who are affected by the situation. I am deeply grateful for the time that you've taken out and for the heart that you've given us today. Again, for our listeners, I want to reintroduce you to Dr. Samah Jabr, coming again from Palestine to join us today for this conversation. For folks who want to learn more about you and about your work, what is the best way to do that?
Simply, they can Google my name. They will find plenty of information. They can follow me on social media, my Instagram page at Samah Jabr. And it's easy to find plenty of material in different languages, including English.
Thank you again for your work and for this conversation. I appreciate it.
Thank you.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.